Good morning or afternoon, everybody. My name is Irene Navis. I'm one of the coordinators for this DRC group, Triage, Infection Control, and Decontamination focus area. We're going to be talking about tools and strategies for effective hospital decontamination operations today. We have a couple of great speakers for you today. We're very excited to hear from a couple of folks from Arizona that will introduce themselves later to present to you information that you've been asking for as we do polls and ask questions. Decontamination always comes out on top. And so we wanted to make sure and give you another thorough couple of presentations on the whole issue of decontamination. Next slide, please. Couple of acknowledgments and disclaimer. The Pediatric Pandemic Network, who is hosting this session today, is supported in part by HRSA of the U.S. Department of Health and Human Services as part of cooperative agreements and not financed at all with non-governmental sources. The content presented here is that of the authors and does not necessarily represent the official views nor an endorsement of by HRSA, HHS, or the U.S. government. Please go to hrsa.gov for more information. Next slide, please. This is a disclosure of relevant financial relationships. The planning committee and presenters have no relevant financial relationships with the ineligible companies. There's no financial or in-kind commercial support for this activity. There is a possibility of joint accreditation and some credits that you can get if you're in certain groups. There are requirements for the CE credits that you see there, and we will give you some more information about how to go about accessing the process for those credits. Next slide, please. We have 3 learning objectives today. We're going to discuss policies, exercises, and resources for decontamination. We're going to summarize options on how a statewide healthcare coalition can support statewide exercises and instructor training. And we will identify strategies for how hospitals and healthcare coalitions can work together to support pediatric disaster planning and response. Next slide, please. Welcome to those who have joined a little bit late. We are very excited to have a full program today. We have Jamie Beauvais and Timothy Frund from Arizona, who will be introducing themselves in more detail a little bit later on. And Dr. Glom will take us through a Q&A discussion. So please, as the presentations are being made, please get your questions ready so we can have a good discussion. And then Laura Aird with the DRC is going to be giving some PPN and DRC updates. Next slide, please. Okay, I'm going to introduce now Jamie Beauvais. He's going to kick us off. He is going to be discussing the As Chair Hospital Emergency Response Team. So please give your attention to Jamie, and we look forward to having him answer questions after the second presentation. Go ahead, Jamie. It's all yours. Thank you.
Thank you, Irene. Appreciate it. So thank you for inviting me to this meeting, and I want to talk about Decon and hospital, how As Chair has developed a program that's unique across the country. Next slide. Okay, so Jamie Beauvais, I am the Central Region Manager for the Arizona Coalition Healthcare Emergency Response. I'm also the statewide training and exercise manager for the coalition. Next slide. Okay, so in 2020, right in the beginning of the pandemic, we wanted, the coalition and several hospitals wanted to build a training program across the state of Arizona, and how we could share resources and knowledge from one hospital network to another hospital network. So on the screen yourself, you see you see a lot of facilities, government entities, hospitals, Banner Health, Dignity, Valley Wise Hospital. We wanted to come together and share resources when training. So one thing that the coalition did do is we send people to a training center in Anniston, Alabama. After they're certified, they are instructors. Then those instructors become volunteers for the coalition, and they can travel anywhere in the state of Arizona and teach at other facilities, which is a cost saving for the facility that is hosting the event itself. So we just wanted to bring everybody in from other networks and build partnerships across the state of Arizona. So everybody's networking. Everybody knows everybody that's in one HERT program in Phoenix area, in the Tucson area, or even in the Flagstaff or on Navajo Nation. Everybody knows who each person is. So that's what we wanted to build, and since 2020, we have built this program out a lot. Next slide. Okay, so the coalition itself, we're divided up into four regions. A lot of coalitions are just certain areas of your state or something. For the state of Arizona, it's one coalition, but we're divided up into four regions. We have 107 hospitals in the state of Arizona. Our membership is hospitals, long-term care, anybody that has to be licensed in the state of Arizona in healthcare, they join our group, and it's all free. And it's through the HPP program itself. Our other community partners, our tribal partners, public health, emergency management, they all work together. One of the other professional organizations we have is the 91st Civil Support Team. I'll be talking about that later, but combined with the local fire departments and EMS and poison control, we all work together to build the coalition itself. Next slide. Okay, so the first step, the HERT program, what we wanted to develop is that the training program is designed to meet standards from the Center of Domestic Preparedness, CDP, that's located in Anniston, Alabama. It's preparedness health professionals to operate a hazardous material incident at a level of they have to do decon. And that decon is basically deconning the individuals that at a event like a mass casualty incident or hazardous material event. And when patients are coming to, they get decon at the scene with the fire department. But what hospital decon, the HERT program does, it gets into it a lot deeper. So we make sure the person is clean before they go into the hospital itself. That is key, because you want to protect the hospital, the house, so your employees, your staff, other patients that are in your hospital, they're not being contaminated when patients are coming in. So we are making sure this is structured by CDP, still looking at OSHA regulations and state policies, and to make sure everything is where it should be. And also each hospital has to have their own policies and procedures. Next one. Okay, we're going to get into training, and this is where the coalition and all the hospitals get together. Next slide. So On the road, so we always say on the road because we we will get a invitation from anywhere in the state of Arizona to help train their new employees in the HERT program itself. So there are so they will submit a request to as chair itself. I will look at the training records and all that stuff, the calendar basically, and see when we could put a class in. Then I will ask my volunteer base, and we have over 60 instructors across the state of Arizona, and I try to find local instructors to come to that facility and do the training in itself. In 2023, we had an advanced course that was new for Arizona. It was 32 physicians that we actually went through. They went through the whole HERT program. And I think it was very important and key to the new physicians that were just graduating because they understand the reasons why decon is so important to the hospital itself, because you just can't let anybody in without being decontaminated. Next slide. Okay, so when we do the teaching, there's several ways, and we have to pivot sometimes. When we've been doing training for the last 10 years, 11 years, we were teaching the big tents, pushing, making sure there's a lot of people going through the tents. What we've seen in the last 10 years, we don't see big events like this. One thing we wanted to make sure is we had to repivot our training based with CDP and everybody else's needs. And one thing we were looking at is other ways to do decon instead of the large tents itself. And I'm going to go into the next slide. And this is where we went to something different next. Okay, thank you. So we focus on decon showers. Most of the facilities in the Phoenix metro area, in Tucson area, and some rural areas, they actually have decon showers. So we teach both methods. So they put their gear on, they go through the steps of tight corners in a shower and making sure the individual is cleaned and make sure they're not exposed to the contaminants anymore. So that was one way we provide something different than because one thing that we also saw is when we said we looked at how many events actually happen. Valley Wise is probably the most the one that uses decon the most in the state of Arizona. They're a county hospital. I'm not going to take Tim's stuff away, but they focus on the tents and the showers. I talked to the other facilities, and they were going more, instead of setting up the big operation tents, because the focus is one or two patients would be coming in, and putting a tent up and putting that much resources is not cost effective. So using the showers is more cost effective, especially when you only have 1 to 5 patients. And that all depends on the size of the tank that holds contaminants when you are deconning the patients itself. Next slide. Okay, Center of Domestic Preparedness resident training. So you could go to the CDP website and get this free training, and it is a great place to do it. It is a old military base in Anniston, Alabama. It's let's start with all the things that a lot of people want to hear. It's all free. The flight is free, the training's free, the food's free, the lodging's free. The only thing CDP doesn't reimburse is your salary. But if your facility could send you to this training thing, you will be a trainer for the HERP program itself. In the last 4 years, the coalition has brought cohorts, basically everybody from Arizona, to go through this training. And the reason why I pushed those cohorts from Arizona, you're building relationships, and that's the key thing. Building those relationships from one hospital network to another hospital network. If it's tribal hospital or a county hospital or other hospitals within the regions. It could be acute care or a level 3 hospital. You bring in all those individuals into one thing for 1 week training and builds teamwork. And even as chair, our employees, I actually send them to these courses so they can get to know our membership also. But this is one thing. Oh, so you learn everything about the HERP program. You'll learn how to don all the equipment on a old military base. It is a hospital. There was a hospital there, so they used that facility as doing the decon. So it looks like you're at a hospital, so that's a good thing. At the end of all the training, you go through a integrated capstone event, and that's what it is training. The lower picture on the slide deck is actually the exercise itself, and they bring volunteers in from the community, and they are great actors. They test your skills that you just learned in the last 4 days. They test you to make sure you are doing this properly and correct. Next slide. Okay, so the medical response surge exercise, we have these, that's one of the exercises we have to do all the time. For the coalition, it's a requirement for the HPP grant from HHS. One thing about the Mercy exercise is we actually have hospitals do their decon training in here. So they will set up their operation through the exercise. Valleywise has done it several times, and it just keeps their skills going all the time. So anytime I can incorporate her into a functional exercise, I encourage other hospitals to do the same. Next slide. Okay. So we just talked about the Mercy exercise. For the Central Region, we looked at mass casualty events. But one thing we do train in the HERP program for special needs. One thing that it's been a dilemma across the whole country is how do you decontaminate a wheelchair or a device that's electronically? And in the HERP program from CDP, we're doing a lot of water and a lot of soap. So between Valley Wise, myself, and 91st, we're looking at other opportunities to do dry decon so we could still decontaminate the patient, the apparatus, the wheelchair, electric wheelchair, or any electronic device. We want to make sure that device stays with the patient all the way into the hospital. So we actually, when I did have my exercise, I do put some injects in there. One was a service animal. How do you decon a service animal? And the other one was a tilt power wheelchair. So we do use this type of injection to training. Next slide. Okay, the drone footage you're seeing right now is important to training and exercise itself. In the training methods, I'm a drone operator for the coalition. We do fly our drones. This is Valley Wise Hospital. And we take pictures of how they set up the operations. It gives a better point of view for the hospital itself, the instructors at the facility, and planning for any events. So without getting too deep into this, I actually bring my drone all the way up to maybe 3-4 stories, so the facility can get a higher view of how traffic should be coming in. How would the ambulance be dropping off the patients, and where would the patients start going into the decon tents itself, and how do they arrive into the facility? So drone operations, I've been using it for about 5 years right now at other facilities, so they can get another perspective of the event. I personally would not be pushing a drone up there during a live event, because I'd be pushing contaminants. That would probably be more mounted videos, but it's a new tool for training and exercise for drones. So if you have wanted to look at something, this is a drone can assist you in that. Okay, next slide. Community partners. Okay, I'm going to talk about a couple community partners that actually help us out a lot. Next slide. Okay, so this 94 Civil Support Team. I go there once in a while. I'll bring other members in, and they do a dry decon. So it's training from professionals from the Army and Air National Guard unit in the state of Arizona. They actually show us how they do decontamination and dry decontaminations, and they have a bunch of other tools and trucks that could get sampling done if needed. One thing I like about the 91st, if we ever had a mass casualty event or a decon event, we could, if they're available, we can actually call them in and they could assist us with that, or assist the facility. Next slide. And this is currently we go to the fire chiefs leadership conference, and we talk to the fire chiefs about this. We talk about the decon, because we want to make sure all the fire chiefs in the state of Arizona understand decon, because they do gross decon, and that's just a lot of water and getting the patients into the ambulance or ready for shipment. For the hospitals, it's a little more technical, so we do share information so they are aware. So once a year, I'm always at the conference talking to the chiefs, talking about decon and how hospitals respond decon and how fire departments, and so everybody understands each other's point of view. Next slide. Community exercise, and this is going to be a fast one. Hit it again, one more slide. Okay, on a community exercise, it was just pictures. Yeah, it's just pictures of basically Valley Wise was just doing a community exercise several weeks ago, and you'll get more information with Tim. but we do community exercise. And the thing about it is, when Valleywise does a training, a community exercise, we bring other hospitals in so they could observe or actually participate in the exercise. So we keep those skills going up. And next slide. Any questions? And Tim, I took 3 of your minutes. I'm sorry.
Oh, no, we're fine. I think we're still on schedule.
Okay, Tim, I'm going to leave it up to you. Go ahead, Tim.
Hello, everyone. I'm Tim Freund. I am the supervisor of disaster preparedness at Valleywise Health. My background is as a paramedic out in the field for almost 30 years before I decided to take a retirement job. And I did want to highlight a couple of things that Dr. Walter's been throwing into the chat. Great resources about decontamination, mass decon, dry decon, etc. So definitely take a moment to download those as we get into it. May I have the next slide, please? So I'm going to speak to you about our Valleywise Health Hospital Emergency Response Team. Jamie's referenced it, kind of gave you the 10,000 foot view. I'm going to get us down to like the 1,100 foot view as we get into some of those details. If you have questions later, my contact information is there, and I believe it'll be available in the slide deck as well. So next slide. Let me first describe what Valleywise Health is all about. We have 2 helipads, a rooftop and a ground level helipad. We have a licensed bed capacity of 233, which we're always pushing because, well, we're kind of a smaller hospital, but we are a ACS level 1 adult trauma center. We are applying for a pediatric trauma center status. We lost it during the pandemic due to low volume. We have a 60-bed emergency department, which makes us a fairly large, but not the largest emergency department around the valley. What really makes Valleywise Health unique is the fact that we have the Arizona Burn Center. We have an entire floor in our new hospital dedicated to burn. There's a separate burn emergency department where EMS patients can take them directly to that burn ED, bypassing our regular emergency department. The only thing that would prevent that is if there was trauma associated with the burn, they would be stabilized for trauma first. So beside the burn ED, we have a burn ICU, very robust burn ICU. We have burn acute, like regular hospital burn rooms. We have a pediatric burn section. There's also a burn clinic and burn rehab. So like I said, very robust. And this is one of the reasons why we spend so much time talking about and practicing both small scale and large scale decon, because if somebody's going to be exposed, if there's going to be a large group exposure to chemicals or a fire, this would be something we would have to be able to do. And as Jamie mentioned, doing proper decontamination, that makes you the first line and the last line of defense before contamination makes it into the hospital and potentially incapacitates your healthcare system. So besides all of our trauma services and everything else, we also have specialty services for labor and delivery, a NICU, PEDS, PICU, regular intensive care unit, and then our med-onc and surge trauma floors. Since we have a tremendous partnership with Creighton University, there's numerous residency programs, surgery, anesthesia, ED, and part of that emergency department or emergency medicine elective, we keep trying to draft some of these baby docs into taking some of our classes so that they have a better understanding of how they may play a role in their future roles with other healthcare organizations if they move on. So our hospital emergency response team is a multi-purpose team with an emphasis on patient decontamination. We often spend a little bit of time training our HURT members on how to use evacuation equipment, whether it's a med sled or a stair chair. We spend a little bit of time training them on incident command because we may ask them to fill in certain roles on our hospital incident management team. But most of our training is oriented towards performing decontamination. We can don our level C PPE. If you've been through the class, that means you have a chemical protective suit, you have a powered air purifying respirator, which is what PAPR stands for, and then you have chemical, biological, radiological, and nuclear filters, which help to filter out any contamination that you may get as collateral being around people who are contaminated. So we are not a hot zone operation. We are very much a warm zone. And while we collaborate with our first responder partners, not everybody who's been contaminated by something shows up by an ambulance. So we take that to heart, and we are prepared to decontaminate people on our doorstep if necessary. When we look at all of our capabilities, if we were fully staffed, we could decontaminate approximately 35 people per hour. That would be 30 people through our ambulatory tent lanes and approximately 5 people through our non-ambulatory tent lanes. And because non-ambulatory patients are typically going to be more severe, it would take more time. And then with our ambulatory tent, we have multiple lanes, so we can decontaminate multiple people down multiple lanes at the same time. Next slide, please. Our origins, they go back before I got here. I've been here in the role for about 2 years now. Back then, we were called Maricopa Medical Center, and some of you, if you've been in Phoenix, may know it as County Hospital, but I have to put a quarter in the swear jar. We're now known as Valleywise. So what we have today is a combination of clinical and non-clinical staff to make up our HURT team, because who's going to be in short supply during a mass casualty incident or a patient surge? And it's going to be your clinical staff. So you'll never have enough nurses. I can't take them out of the hospital. I can't put them in a level C PPE suit and get them physically overheated and exhausted. So we do have heavy support from our burn center staff. It's actually written into job descriptions that if you get employed by the burn center, you need to come through our HURT class. So that's one way of having a robust team. That includes our RNs, the certified burn techs, and the burn physical therapists. So even though they may not be directly touching a patient in their first 30 to 60 minutes in the hospital, like our burn physical therapists, they're still all trained, because we can stop physical therapy when we have a mass casualty, and we can redeploy those people. We take RNs from the ED, but again, that's kind of a wasted resource. We at least know that they're there, but we need our RNs in the ED. But we also have med-surg, labor and delivery nurses. We get people from PACU and pre-op and OR. We take certified nursing assistants from the emergency department and other departments as well. But then I think what's really niche, because Valleywise is a safety net hospital for Maricopa County, and we also have a very large refugee population. So we have several interpreters on our team, and we have biomedical technicians. We even have security in facilities. Security because, yes, we may have to provide a perimeter security, but also because in Arizona, people may show up with guns and knives. So we have to have somebody who can take those into possession, prevent that from causing any further harm. Facilities is not just for the power and water. We train all of our HURT members to be utilitarians and run our own power and water, but facilities can also help us with drainage. They can get suited and booted into the level C PPE. So I mentioned we have over 200 staff members currently trained, and we have this capability at our main campus in downtown Phoenix, about 1.5 miles north of Phoenix Sky Harbor. And then we have a standalone ER that still has decontamination capabilities, but on a much smaller scale. No tents for them. If it got that big, we're going to call out help through the coalition. Next slide. So I was looking back as I was trying to put together this presentation, and I'm like, wow, these are some really, really cool old pictures. And I almost have to question why we were putting on PPE to set up the warm zone. And I think that's something that we've changed. So if that's how you train, put on your PPE and set up your emergency treatment area, I would encourage you to change that methodology. First of all, it's all of the mobility risks of trying to do this in level C PPE. Second of all, it's physically demanding, especially here in Arizona with our work rest cycles. I might be halfway through setting up a tent before I time out in my suit. So just understanding those things. And then just another fun picture, training in a classroom. Here we are practicing cutout, getting clothing off of one of our inflatable mannequins. But again, this was long before my time. Next slide. So for any active incident that would activate our hospital emergency response team, we identify a team lead who tends to operate autonomously for most activations because it's small scale. It's usually a onesie, twosie kind of scenario. However, if there is a large scale, a mass decontamination scenario, which we define as 5 or more, they would operate under the ops section chief. And I think this is pretty standard for most organizations, who in the first phase is going to be either the ED charge nurse or the ED manager, and they will request additional stuff or staff or both. Outside of our active instance, so for all training, for all organizational things, for new policies, procedures, oversight is provided by disaster preparedness and emergency management. And part of what we do is incorporate mandatory quarterly training. We deliver it in person, live virtual, and then we record it. And for people who work nights, for people who are on PTO, they get assigned that recording through our learning management system that they can stay up to date on any changes that we have discussed during our quarterly training. Also, to take care of all of our inventory, maintenance of that inventory, and making sure we have adequate supplies. That's also managed by emergency management. And then any training that we conduct, because we know people's time is valuable and it's really hard to get volunteers these days, all training that they may go to, whether it's in our organization, outside of our organization, falls under our emergency management cost center. So we are fortunate that we budget for it. It's never big enough. I always have my boss in my ear saying, we're over budget. And I'm like, well, give me a bigger budget next year. Next slide, please. Part of our prerequisites to attend our HURT course internally is to take the independent study classes IS 100, 200, 700, and 800. If you're trying to take those classes right now during the government shutdown, those websites are inactive. Ironic, because it's an independent study class. Anyways, hopefully things rectify themselves shortly. So we do provide an indirect delivery of the CDP HURT class. Through Jamie's assistance, we publicize this both on the As Chair site, and then I send additional emails out to other organizations. It's a 10-hour training day, 2 more hours than what the CDP provides for the indirect delivery course, because we incorporate the skill stations along with the modules. Because this is part of the parameters with the CDP, this training is open to all community partners at no cost. I had a ham radio operator from another healthcare organization sit in on my training earlier this year. Like, everybody's welcome, because I think this is important information. And then we have approximately 15 staff members who did attend the resident training at Anniston for HURT Train the Trainer, and they help regularly support our internal classes. While I am the supervisor, I am not a one-man show. I actively try and engage other people because I don't have all of the experience, and I rely on our team. So we do have a separate cadre of our own instructors within HURT for ValueWise. Next slide. So picture on the left, some of our people. This was a sponsored class where more than half of that class, or approximately half of that class, came from ValueWise. You don't care. I recognize the pictures, but it's always great when you can go to training with somebody else from your organization, because it's like that safety net, but also you help build a lot of bonds. When I attended my HURT Train the Trainer, I'm still in touch with my immediate group of people that was in HURT with me. We talk about disasters in our area. We talk about, hey, we're going to be in this area. We share little stories and training ideas back and forth. So training, we start by doing a little bit of donning and doffing of our PPE. We use our live PPE in training, and that also affords us an opportunity to do like an inventory to make sure that everything's still working. What we don't use as live is we use old filters. We don't use live filters when we do that. So that's our fun little picture with one of our HURT slides in the back. On the top right, if you look, we do have a service animal in the classroom with us. And this was not an animal that we ended up decontaminating later. We had a member of our organization tell us that they wanted to attend HURT training. They said, but I have a special needs accommodation. And I'm like, yeah, sure. They're like, I had this conversation with my leadership. They're like, the dog, they can't get suited and booted. But I said, being part of HURT is not always about getting dressed out in level C PPE. We need HURT leaders, we need screeners, we need safety officers, we need people to do power and water. We made the accommodation for the service animal. Everyone was happy. So don't let people's physical limitations or their special needs request prohibit you from having that resource on your team. Next slide, please. So we have our own separate policies and procedures that are mentioned in the EOP. We have like a 37-page standard operating procedure. And within that, we define the small scale of being less than 5, and then mass casualty decon 5 or greater patients. So for small scale, we would use our hardened interior shower. For anything larger than that, we would start talking about setting up tents. We also have medical screening forms for our staff as they get suited and booted. We want to make sure they're within acceptable physical parameters. We borrowed these parameters from the CDP: heart rate less than, I believe, 120, blood pressure less than 150 over 90, respirators less than 20. And that's just for our safety. It's all managed by our employee health and wellness section as well. We have our own documentation forms. We've revised them recently to incorporate a picture of a body so that we can identify where that person was exposed. And that's a good piece of documentation for our burn team who might not get first hands on them. And then we have additional resources like the ERG. We use the ERG apps. I do strongly encourage anytime we activate one of our decontamination events, known as a code orange, to contact poison control and have that doctor or that special subject matter expert referenced so that we can have that documentation and that support. And then what's unique to Valleywise Health is we have our own toxicology program. So we can also contact one of our toxicologists internally if we need advice, how long to decon, any special activities within that. Next slide, please. So some excerpts from our EOP, you can see where it talks about the low casualty, small scale response versus a full scale HURT response for a mass casualty activation. And just a couple of highlights: all patients that present to the hospital that have been contaminated with any hazardous materials will be decontaminated prior to being brought into the hospital. We put this out here because not every medical intervention is going to be performed on people. The best medicine is cleaning the patient. Now, we do practice what the CDP preaches, and we do limited life-saving interventions like tourniquet application. We do have an anesthesiologist who is trained to get into level C PPE, and they could provide airway management if necessary. So just other things to kind of think about to that aspect. Train your physicians, physician participation, anesthesia, because if you want to be managing a patient's airway, that's typically not something that falls to anybody else, and you have to be trained beforehand to get into the suit and perform the intubation itself. Next slide. So here's our separate SOP. It outlines our entire program, training model and requirements, the respiratory protection program required by OSHA, what kind of personal protective equipment we have, how we're notified, a standardized safety briefing that we give during training, that we give in classes, and then for live events, the medical screening form. We define our 3 emergency treatment areas: a primary, secondary, and tertiary one, and what it takes to set them up, our triage practices, decontamination procedures, and then we have all of those job action sheets or job aid sheets for our HURT team lead, for safety, for a screener, and those screening sheets. Next slide. Some of our excerpts, particular ones that you need to have a medical director, should be chosen from your attending physician staff. Ideal candidate would have prior experience with hazardous materials, and especially similar to that, emergency medicine, burn surgery, trauma surgery. The medical director has duties to collaborate with the HURT program directors and the subcommittees to talk about any medical policies pertaining to. We did some training recently and decided that we wanted to have some standing orders for intranasal medication administration. Didn't previously have those, working with our physicians, our medical director, to develop those as we speak. Also to replace tourniquets and splints and other interventions that may have been applied prior to arrival at the hospital. And then we'll also accept residents because they need that experience about being a medical director. And then our activation process, it talks about how when we activate, we're using a overhead page, we're using a mass notification system, and there's the possibility of using a phone tree. Next slide. Because this is the Disaster Response Collaborative and we're talking about the Pediatric Preparedness Network, we wanted to talk about some of our specific pediatric considerations. So reminding people removing clothing removes most of the contamination, sensitive skin soap, etc., to decontaminate the skin. Families will be kept together whenever possible. The water temperature should be maintained to reduce the risk of hypothermia as well as burns for our younger and our older patients. Decontaminating kids takes longer. So it may take more time for that. And older children, especially teenagers, may resist decontamination out of fear of being exposed, completely exposed, peer pressure, brother, sister, other kids, the same or opposite gender in the tent with them. But we're fortunate that we have a 3-lane tent and we can put families down the center lane if necessary. Parents and caregivers may not be able to decontaminate both themselves and their children. So the smaller the child, the increase the difficulty and the challenges you have with that separation. So plan for these things, especially because children cannot be carried through our decontamination process. So we use laundry baskets for small children. They go down our non-ambulatory tent along the roller system because the last thing you want to do is add trauma to this burn exposure. And then another excerpt, children under 2 go in the laundry basket. Children 2 to 8 may be assisted by their parents along with one of our HURT members, and then 8 to 18 should be able to wash themselves with minimal assistance. Next slide. Here's some supplemental information from our physician oversight group, just to help kind of define some of these things. If you guys want some of this information afterwards, you can reach out to me by email, and I'm happy to share this with you. Next slide. So we have a HURT locker. If you're fortunate to have a lot of stuff, which we are, it's important to have that stuff where people can get to it. So we have badge access into our central utilities plant where all of our stuff is air conditioned. So that does extend the shelf life of things. That top center picture, there's a lockbox with the layout of the HURT locker. Once people use their employee badges to get in there, they can open up the lockbox to get a key that opens up the overhead door so they can pull the stuff out. They don't have to wait for emergency management to do this. I don't do nights and weekends. I used to, I don't do them anymore. So we also, on all of those carts that you guys can barely make out, we have a par list and a map where the cart and the contents go in relation to our primary ETA. And there's a sequence for everything to come out. Next slide. So our decontamination spaces that we have our primary ED decon shower for our wet decon operations. It is primary use, negative pressure. There's a door from the outside. Once they're clean, they can go through the inside door. We have 2 shower heads, a vital sign monitor, and even the med gas panel where we can deliver oxygen and suction if necessary. We have a rooftop decon shower that was planned before I came into role, and I really discourage people from having a rooftop decon shower because as a prior flight medic, most of the time if my patient was even the least bit contaminated, they didn't get in the helicopter because pilots are scared of germs, and I'll just leave that out there. Our primary emergency treatment area for wet decon operations is in our ambulance driveway. You guys saw some of that with Jamie's presentation. We're capable of running an ambulatory tent, a non-ambulatory tent, and a technical decon tent simultaneously with hot and cold water coming from the building itself. So we don't need water heaters, we don't need hydrants. We're pretty fortunate with that. And we have enough hoses and a plan to do gross decon because it's going to take us time to set up our emergency treatment area. Next slide. So a couple of pictures of our outdoor shower. Here's security. We try and set a perimeter around that so that if you enter into this zone, you are warm, you need to be cleaned. You see that we have a PVC and mesh stretcher that we can bring out to the EMS stretcher if necessary. Next slide. Moving in, here we have our double buckets. We don't have to bend over, our 2 shower heads. In the center picture, we have a timer with that yellow button so that we know how much water or how long the patient's been getting decontaminated. You start the timer when you start the water and you start washing the patient. When 5 to 8 minutes are up, we can recheck their pH or check them with M8 paper, et cetera. And then we have a vital sign monitor because a lot of times if they show up by EMS, they've already received pain meds and we are obligated to monitor their oxygenation, their heart rate, their blood pressure, their respirations, and their end tidal CO2. We even painted on the floor the warm zone versus cold zone so that as they go into the hospital, we don't cross that line and we don't contaminate our emergency department. Next slide. We have a decon support space. So we have all of our equipment in the, like our suits, our PAPRs, our hoods, our boots in the room next door to our decon shower. I love the picture in the center. We have ice, we have coolers with ice vests because yes, it's Arizona. Even inside in those suits, if you've ever done level C PPE, it's hot and sweaty. So this is how we extend our life by wearing those ice vests. Next slide. So here's a better picture of our ETA fully set up. We went through a couple of different iterations and revisions, but we continue to drill this. People bringing equipment. Those yellow overpacks are valuable for anything that's contaminated after the fact. Next slide. And it does take a lot of setup. We've minimized the need for the forklift, but we have hose ramps to take water and power from the building. And you see the ambulance in the background. We only operate out of half of the ambulance driveway for our decon operations. The other half of it would stay open for non-contaminated patients. Next slide. And because only half of our day is lit, so we also train into the evening. We have a HERT decontamination drill coming up October 23rd. That starts at 5 in the evening. If you live here in Arizona, sun sets at 5:47 that day. So our goal is to get the tents up before it's dark. And then once it's dark, we have to put lights inside of it. So here you can see we have lights inside some of that, which requires electricity and or a generator. Training in our live space because it's important to do so. Sometimes before we opened, we did a live exercise so that people got used to functioning in there. And then as Jamie mentioned, service animals. So we find people with dogs, we find people who are willing to get washed. Obviously the patient takes priority, but we can wash the service animal as well. But I can tell you from having worked with canines in past lives, first thing you need to control on a canine is the muzzle. So taking gauze and wrapping that up or using a medical muzzle if available, because we would also have law enforcement officers potentially come in here along with their working canines. Next slide. We already kind of talked about this. I know we're getting close on time. We started adding alert media for our notification, but we'll move on to the next slide. Some of our training, because it's hot in the summertime and I don't want to train in a full suit, but we still need to practice checking pH. Sometimes just using the sleeves from old suits is a great way of doing survey and monitoring training without smoking people in our hot environments. We do have that rooftop decon shower, so we do have to train on that. We're going to do it once every other year, but here's a great picture from that episode. The patient was flown in, potentially exposed to a chemical, and our team got suited and booted on the rooftop and went out and met the flight team. Next slide. Training in the summertime is a little bit of a risk. So we usually in the summertime, we'll move everything indoors into our simulation center. So if we're not actually in the scenario, we're watching the scenario from the classroom on the right. Next slide. I pulled these pictures because here we are practicing for decontamination of pediatric patients. So we blew up our little inflatable child mannequin, put them in the laundry basket, put them in scrubs, have to cut out of there and move them through the roller system. And then the picture on the right is one of my coworkers, teenagers. So that does qualify as a child. Adolescent child, we put her through this as well, putting scrubs over top of real clothes to protect modesty. And then she really did get wet that day. This was in November and she was not pleased with the lack of warmth of the water, but we fixed that problem. Next slide. We do have an annual training requirement, 12 hours. This is for our safety and proficiency of our teammates. We do 4 quarterly meetings that are 1 hour and then 2 5-hour drills. That helps people meet that requirement. We do about 6 drills. 3 of them are based upon our ETA, our emergency treatment area. We incorporate the reality-based training scenarios. And then we use simulation. We were talking about access and functional needs, law enforcement, and pediatrics. And then we're planning on doing no-notice huddle drills for 2026. And then if they go to other training, we honor that as part of their recurrent training. Next slide. And if you ever get the opportunity to practice in your alternate emergency treatment areas, you can see how large of a footprint, how much space, staff, and stuff this takes. This was a great collaboration with one of our partners from Honor Health. Next slide. And don't always talk about decon. Sometimes it's about evacuation and incident command. So a couple of pictures. We do a lot of things live around here. Putting real live bodies in real evacuation equipment brings a different level of reality to things. Next slide. Everybody asks, where do you get the money for it? Well, I was lucky to inherit most of this stuff. We're always pursuing new grants, capital expenditures for larger ticket items like a trailer that we just received. Now we can be more mobile with our HURT equipment if requested through the coalition. And then most of the training for the non-salaried staff. So I'm just as short on the budget as most people are, but we'll keep looking at the grants that might be out there. We'll also look at private partnerships with corporations that may have obligations to do that. Next slide. And I think that's all that I have. I ran over a little bit. I apologize, Dr. Glum, but were there any questions for me?
Yeah, thank you very much, Tim and Jamie. Really outstanding presentation, super informative, and really help kind of lay the groundwork for how all this can be done. We do have a number of questions that are in the chat, and I'm just going to read them out, and then instead of breaking or going into breakout groups, we're just going to keep it in a large group. So once we finish the chat questions, we can go ahead and open it up to anybody else. So I'll just go to the first one. So how do you triage patients who arrive in ED during a mass decon event who are not involved in the contamination? So like those that are coming in for a separate illness.
So the first part of our emergency treatment area is our security point, which helps us filter between contaminated and uncontaminated patients. And because we're going to use our ambulance driveway, we put that point at the very beginning so that as ambulances are coming up, we ask, hey, was this person from the scene? Are they exposed? And they say no, then we can filter them to outside of the ETA and prevent them from coming into it. But if they were like, I don't know, or we're not sure, we filter them into our ETA completely adjacent to that. If you have other patients who are showing up at the front of our emergency department, the public entrance, in that situation, we would want to have security present, and we would direct them on foot to come around to our emergency treatment area and to influx them through the only checkpoint in, and therefore they can only go out through the only checkpoint out. So that is important to work with your security teams, as I mentioned, to help set a perimeter and to have that patient flow.
Great, thank you very much. The next question was regarding medical screening for staff. The question is this done before they can join the HURT team as a one-time thing, or is it done before each event?
So it's before each event, because you might be having a bad day, your blood pressure medicine might be off, you might be sleepy or tired. I need you at your best effort for that day. So if you're out of parameters, we'll find other work for you. You can be part of our rehab sector. You can be an equipment bearer, et cetera. You can help us do those kind of things.
I want to add one thing to it. Also for CDP, for individual, because that's a requirement for CDP. You have to go through all that stuff. Now, to become a trainer, you could actually tell the instructors that I will not pass the physical, and they could still go through the training, but they will give them other job duties, like triage or safety office or something like that.
Excellent. Thank you. And then also, I think maybe a follow-up here, are there privacy issues as well with not allowing people to partake in the role because of medical screening tool?
We won't divulge that, and we don't let a doctor override that. It's for our safety and our liability, and we're not willing to accept that risk.
Okay, great. Excellent. All right, so let's just open it up. Are there any additional questions from the group? I have a question, but Irene, go ahead. Sorry.
Katie just added, for the walking incoming patients, if they say they're not involved in the event, do they enter the ED by the non-decon area?
They would probably, if it's a mass casualty, we would still filter them in through the only entrance, which is our ambulance entrance. We would have to control our perimeter and not have people trying to do triage at 2 or 3 different points. It diminishes our resources too much. So if they show up at our public ED entrance, we would direct them around and allow them in through the ambulance bay, which is where we would do our triage sector post decon, or if they didn't require decon.
Great. Dr. Glom, go ahead with yours, and then I have a couple of questions.
Yeah, I just, just in looking at the clinical and non-clinical staff that are involved in the HERB training, you had mentioned the cost center, emergency management cost center. Are those that are getting trained actually getting paid to train, or they are? Okay.
Yes.
All right. Because
yes.
I was wondering just what type of incentives are you using? So it's every time, so on a quarterly basis, they're actually getting paid to do this training. Okay.
Yes, for whatever training that they attend, they get paid for, because we can't expect people to volunteer for it. And if it puts them into overtime, because sometimes you have night shift people and day shift people, we have to work within that. Being a county special healthcare district of Maricopa County, we also have to look at those things to make sure they don't go beyond 16 hours, et cetera, and stuff like that. But
understood. And then do they, just to follow up, so if they are activated, do they then get paid for the time that they respond to an event?
Yes.
Yeah. Okay.
Yeah. And you talked about incentivation. So like we have tchotchke that we give out. We've got little badge buddies, and even our lanyards, and we do t-shirts and hats, patches and challenge coins. So we do try and encourage people to keep coming back to the training. If you've made it to 5 drills, you get the 5 drill pin. You get to 15 drills, you get a challenge coin. You get different stuff, and then people can wear it into work and help kind of promote that internally. And for recruiting, one of the things that we do is we go to every new employee orientation and we attempt to recruit for HERT. And I tell people in new employee orientation, if you can wash your hands, you can wash a patient. You don't have to spell CPR, right? So we get people who are behavioral health technicians that are not necessarily medically oriented, and we welcome them. We want food services people. We want EVS people. We have IT people on our HERT team.
There's another question. Yeah. There's another question in the chat, Dr. Glom, that was just added by Shailene.
Oh yeah, okay. So when estimating the time per patient, we recently had a large decon in CT in Connecticut, and fire and EMS realized that all the trainings, drills have people who want to participate and they listen and behave accordingly to plan. However, in the actual large incident, they learned no one listens and people flat out refuse to do certain things. Do you have any way to prep for this or have any experience with this?
So we have not prepped for that, but that brings up a good point. And this is, again, why you need to have security as part of your team. We are fortunate that we have armed security here, and they would have to help us with that, because first of all, we don't want them to go hands-on if the person's contaminated, but we have a megaphone as part of our mass casualty kit that we can deploy, and we can give voice instructions over a megaphone. I know people aren't necessarily going to listen, but that's why we have a security presence and they liaison with local law enforcement.
Excellent. Yeah, go
Also, I
ahead.
want to back with CDP. Me and Tim went through the process years ago, but we still go back. But they do the volunteers. They do press, give you to a certain limit. They will push your buttons. They will test your limits as a decon team. And that's anything from yelling, screaming, no hitting. That's a good thing. But they also will give a scenario of a pregnant woman with an explosive under her thing. So having your security team do going through that training is also valuable because these are extra signs that you may not. There's a lot of great training at CDP for law enforcement and for the HER program itself.
Absolutely. Great points.
Two more
Yeah,
questions.
yep. And just to clarify, so it sounds like there are 3 ambulatory lines, correct? So you're recommending, or what you have is a male, a female, and then a separate family line to protect modesty and increase compliance.
If you have a 3-lane tent system, some people
Yeah.
only have 2-lane tents, but we have a 3-lane tent. So yes, we would do a male lane, a female lane, and then an as needed lane, right? And within the male lane, we would try and have males. Within the female lane, we would try and have females, especially with all the cultural differences that we have to accommodate being a safety net hospital with a refugee population.
Understood. And you mentioned, children and adults with special healthcare needs. Any separate lane or discussion about separating / doing separate decon, knowing the equipment, all the other challenges of those patients?
So part of that would come down to triage and their acuity, right? Because if we get into their wheelchairs and other things, it's going to take more time. We could. They would most likely go through our non-ambulatory lane because if they have special needs with mobility, we're not going to have them stepping in and out of basins and stuff like that. We still have the option of our inside shower that we could utilize for that. But again, that splits our staff resources in different directions. So you have that challenge.
Certainly. Okay, and I think this is, maybe you have time. Do we have one more? Is that all right?
Yeah, we have
Okay.
Mark Baker's question, and then we have
Yeah.
a quick question for Bridget as well.
All right. Do you activate your HERT for patient movement, evacuation drills, and exercises? You mentioned no notice drills. Have you done these on the weekends or after routine hours?
So yes, we would activate for patient movement for evacuation because these people have the additional training and they've already expressed the willingness to help out. We would, for like an evacuation, it's going to be with whom we have in-house, but then we can also request additional people to respond in for something more of a sustained operation like incident command. So we do drills on weekends and after hours because that's when, I mean, there's only 40 hours during the week that is completely staffed in theory, right? And that's less than a quarter of the week. So we do train to nights and weekends with a lot of our exercises.
Just want to remind folks.
Yeah, go ahead.
Sorry,
Eileen,
Dr. Blom, the session evaluation link is in the chat. Please fill it out. Also, we were talking about funding earlier, and those of you who have been along for the ride, I think it was the first or second session, I did a piece on funding sources for decon and other CBRN related activities within your hospital. So please refer back to that for additional information on funding. And I did want to just ask a quick question about as part of your training, do you also address the broader ICS, the community level resource request process for the civil support team and other resources that you need? Thank you.
So for our HERT team, a lot of that would come through one of our emergency managers if we had to request resources outside of our hospital.
And for And for if the request went through public health or myself through the coalitions, we could push that up to our state health department and Department of Military Affairs, which is where the 91st is housed. So, and that's for us, that's phone calls away. That's not days.
Great. And just a tip for those of you who are preparing drills and exercises and maybe a tabletop, one of the areas that is often overlooked is the resource request process and how to go through that. And so that's something very easy to incorporate into your drills and exercises, especially the ones that are being sponsored by the DRC. So take a look at that and see if you have ways to pin that down and tighten that up as a policy procedure, and then exercise it. Anything else, Dr. Glom or Laura, before we close out?
I think that's it. I just really, well, from at least, I would like to just say thank you to Tim and Jamie. Really appreciate your time and sharing your expertise and experiences. This is invaluable. So really appreciate you both. Thank you.